Daniel and Catherine. So Catherine Ridereau Zins is a radiologist in Angers. She's dealing with body imaging, and she will talk about colon cancer. Thank you so much.
Good afternoon. Good afternoon, everybody. I'm very happy to be here in a so kind country, and I will thank Laurence. She's a magnificent lady. So, what we absolutely must know about colon cancer. Colon cancer is a modern-day public health problem with more than 40,000 new cases in France in 2012. 5 to 6% of the French population will develop a colon cancer, and most of them before the age of 50. So, basically, the diagnosis of colon cancer is based on colonoscopy, optical colonoscopy, which allows to see the lesion and to perform biopsies. Imaging is helpful if colonoscopy is impossible or incomplete in emergency situations such as obstruction or perforation, and of course for the staging assessment of the cancer. In fact, there is 3 situations in the colon diagnosis in imaging. First, investigating polyps, which are premalignant lesions. Second, when there is a clinical suspicion of colon cancer. And third, complication, obstruction or perforation. And for each situation, there is 3 types of examination. Investigating polyps, this is not my topic today, but it is in case of personal and mass screening when colonoscopy is failed or refused by the patient, and the exam that you have to perform is a CT colonography, virtual colonography. You are looking for this lesion, which is a polyps, an anomaly of the mucosa, corresponding in endoscopy to this kind of lesion. Where there is a clinical suspicion of cancer with diarrhea and constipation, rectal bleeding, pain, or abdominal mass, or anemia, you have to perform a water nemacity. I hope you know this technique in Israel, but I'm not completely sure. You are looking for this kind of lesion, whether the thickening of the bowel wall corresponding to this kind of lesion in endoscopy. And when there is an acute complication of a cancer, you have to perform a simple abdominal and pelvic CT, looking for this kind of lesion. You can see here the thick. I don't understand, sorry. I will answer you later in my lecture. So, in front of an acute complication, in this case there is an obstruction due to this left colon cancer. You can see the thickening of the wall, and this is an acute situation, and you have to operate it on, and you can find this kind of lesion. So, you have to be aware of new treatment approaches, which are very helpful to compute your report. Surgically, colectomy are nowadays performed by laparoscopy for the left, the right, and the colon, the total colectomy. You have to know the early rehabilitation. This is an approach of the peri-operative period for the patient with no aggressivity, no tube, no gastric tube, no renal tube, and in particular, no colonic preparation. So it's impossible during the surgery to practice coloscopy perioperatively. And this is very important. I will explain you later. Liver surgery for the liver metastasis. It depends on the surgical team. They can be performed in the same time as the colectomy or later. And there is also different attitude for the surgery of the peritoneal carcinomatosis with a tumor resection stage, more or less intraperitoneal chemotherapy. The chemotherapy, it's nowadays proposed a neoadjuvant chemotherapy for non-metastatic colon cancer, but with a poor prognostic indicators, in fact, for the lesion T3 or T4. So you can understand that you have to assess if a lesion is T3 or T4. And the third point is the possibility of insertion of the colonic stent, depending on the site of the lesion, of course, and the length of the stenosis bowel. But you have to know that there is some risk of long-term dissemination or perforation, and the surgery has to be performed quickly after the insertion of the stent. So, in fact, there are some questions asked by the surgeon. The first one is, what is the precise site of the tumor on the colon? Right or left? And this is particularly important for the colon on the tumor on the transverse colon, because it's not the same surgery to make a right colectomy or a left colectomy. And moreover, for the small tumors, I said to you that it was impossible now to make a coloscopy perioperatively, so it's really important to know exactly where is the tumor. What is the extension of the tumor? The laparoscopy is contraindicated for the T4 lesion because of the risk of dissemination of the peritoneal cavity. And also, surgeons have to assess the duodenum, the stomach, the pancreas, the left ureter, and the bladder in function of the site of the tumor. Are metastases present? Because where you have metastasis, it's chemotherapy first, not surgery, after surgery later. Is peritoneal carcinomatosis present? If it is shown on imaging, CT, PET-CT, MRI, it's chemotherapy first. If there is a doubt, it's laparoscopic exploration. And if, unfortunately, it's perioperatively found, it depends on the team and of the number and the location of the implant tumor with a tumor resection. And of course, if the colon is preperforative, it's useful for the surgeon to know that before he had to plan shortly the surgery in emergency to insert a colonic stent. So, how radiologists can answer to this question? Water enemicity is a technique commonly used in France. The aim of this exam is to fill the colon with a high quantity of water to perform an acquisition with injection of iodine contrast of the venous face. When you found a tumor, you make in the same time a thoracic exploration. Of course, the enema is drained up at the end of the acquisition. This technique is well tolerated. You have always a good colic repression. Colon property is not required, which is very important for the elderly patient. There is an excellent sensitivity and specificity for the diagnostic of colon cancer. For the elderly patient with incontinence, you can use this kind of bowl to avoid some water on the machine. When you practice the exam, you can analyze the colon wall, a very thin, linear and regular line. You can analyze the lumen. Here you can recognize the water enema. Is the radical fecal residue. And you can also analyze the pericolic fat and, of course, all the abdominal organs. It's very easy to recognize a cancer. There is a thickening, a focal thickening of the wall, just here. Even the surgeon can make a diagnostic. there is a stenosis of the lumen, and you can analyze if there is infiltration of the adjacent fat or not, and if there is lymph nodes. Of course, you can precise the location of the tumor on the colon in multiplanar reformatation and essentially in coronal view. Here there is a lesion of the left part of the colon transverse. Now, and it is the reason why water pneumacity is so special and so useful. Could you have an idea of the T-staging? When you have a lesion like this one, an exophytic lesion, with an external edge very convex, you can say it's maybe T1 or T2 lesion. When you have this kind of lesion, exophytic and here circumferential lesion, with an external edge concave and stiff, there is probably an infiltration of the muscularis and the lesion is T3. And when you have an involvement of the organs, the adjacent organs, here the liver, here the abdominal wall, and here the peritoneum, the lesion is here, and infiltration of the peritoneum is here. It's a T4 lesion and a contraindication for the laparoscopic way. You can also search poor prognosis factor as infiltration of the peripheric fat and vascular involvement, and this is helpful in the idea of a neoadjuvant chemotherapy. What about end staging? We are not really good for the end staging because there is a poor specificity, probably that the peritoneal lymph nodes over 5 millimeters and over 100 announcement after IV are positive, but it's not completely sure. Of course, at the same time, you check the liver metastasis, number, location, and as I said, it's chemotherapy first. You have also to search peritoneal carcinomatosis on CT. Here, in this case, it is obvious with this peritoneal implants. You can help your diagnosis with a TIP CT, and moreover, it's probably useful to perform MRI and diffusion weighted imaging to such very, very small implants, which you can, when you look very, very close on the CT slide, you can recognize this lesion as there is some difficulties for the small tumor. You see in the slides where is the tumor? Use reformatation, sagittal, coronal, and you see that the lesion is on this fold. So this is a very small tumor and very difficult for the surgeon to find it if you don't have precise before where it is located. Don't forget the dual location here on the left and on the right column. Now, in emergency, when there is a colon obstruction, the first diagnosis is cancer. So you have to search a cancer. It's quite easy. It's located on the junctional zone between the dilated colon and the flat colon. You know this kind of analysis here, and on the coronal view here. You have to check some points. First, a colon distress on the second. Here you can see gas inside of the colon wall. You have to check the location of the stenosis in the idea to insert a stent. Here on the sigmoid, it is possible if you have a right measurement of the lesion. Be careful, when you see a peritoneal effusion, it is not necessarily carcinomatosis. obstruction is only fluid, peritoneal fluid in the direction of the obstruction, not necessarily due to implants, peritoneal implants. And of course, check the thoracic to search metastasis. In case of perforation, remember that more often the perforation is located on the cecum. It's a diastatic perforation, and the lesion is on the left column, just here. Sometimes the perforation site on the tumor, but more often it is just before. So, to conclude, treatment strategy depends on the location of the tumor, stage of the colon wall extension and presence of metastasis. A presumed T4 stage cancer is a contraindication to laparoscopic surgery. In case of metastasis and peritoneal carcinomatosis, chemotherapy is given prior to surgery. And the pre-treatment assessment for colon cancer is based on water immunogenicity. And this is more helpful than CT colonography because you are a better contrast between the lumen which is filled with water, the wall which is enhanced, and you can check the liver metastasis at the same time. And more often, you can more appreciate the stage of the wall extension. Thank you.
Thank you very much, Catherine, for this lecture.